Greetings and welcome to the Larry Children's Pediatric Bariatric Surgery Virtual Roundtable. My name is Chad Worley. I am your moderator for this session too, and I'm also a physician liaison for Larry Children's. I am joined by Larry Children's Surgeon-in-Chief, Dr. Tom Inge, and he'll be introducing today's session to panelists, Dr. Karen Mangarelli, who will be speaking on advanced therapies for children and adolescents with severe obesity. But before we go on and I introduce Dr. Inge, I want to remind everybody that these sessions are being recorded. We do not offer CME for these sessions, but we do encourage you to ask questions. So please do so at either the Q&A section or in the chat room. And then after Dr. Mangarelli's session, we will answer all your questions either live or through the questions. And you could ask questions about Dr. Mangarelli's session or to Dr. Inge about our bariatric surgery program here at Larry Children's. But let's take it over to Dr. Inge. Dr. Inge, welcome to session 2. Thank you for joining us today.
Yeah, thanks, Chad. I really appreciate, again, the opportunity to be here. Good morning, everyone. Welcome back to our day 2 of the Pediatric Bariatric Surgery Virtual Roundtable Series. My name, as Chad mentioned, is Tom. I'm the Surgeon-in-Chief and Chair of Surgery at Larry Children's. And with Dr. Mangarelli, whom I'll introduce in a moment, direct our Pediatric and Adolescent Bariatric Surgery program. So we created this roundtable series with the very intentional goal. We'd like to help the broader pediatric community better understand how we think about severe obesity in teenagers and some preteens as well, where advanced therapies, including surgery, including medications, fit in along the care continuum. We would like to be the go-to place for questions that you have about management of obesity in kids, as well as the place that we entrust for multidisciplinary approach to complex and severe obesity. So these services are delivered in a multidisciplinary program with a long-term perspective on this problem and a longitudinal follow-up of these kids after major interventions. Most clinicians, I would say, caring for these kids will find very practical and evidence-based perspectives, as Emily Hobbs gave us yesterday from a nutritional standpoint. I hope they'll be useful, whether the patient is a surgical patient or a non-surgical patient. That path is usually determined by the patient and the families. But here, our bariatric program is built around close collaboration amongst the primary care specialists, subspecialists, nutritional, behavioral health, obesity medicine, and surgeons like me. I think that our emphasis has always been on thoughtful patient selection, shared decision-making with the referring folks as well as the patient and families, and in particular, long-term support, not just on procedures or writing prescriptions for drugs. So with that framing, I'd like to introduce my partner, Dr. Karen Mangarelli, who will be leading today's session. She's an attending physician, pediatrician here at Larry Children's, has been a thought leader in the field of obesity medicine and surgery for some time, coming to us from her prior work at Duke, running the bariatric program there and obesity management program. So she's a key leader within our pediatric bariatric program. She brings this deep expertise on the medical management side, as well as a holistic approach to the problem of pediatric obesity. I think she works closely with referring doctors as well as our team members to help decide when and how and which of the advanced therapies should be considered. So today, she'll be talking about just that, advanced therapies for children and adolescents with severe obesity, an area that is rapidly evolving, and new information, particularly about the GLP-1 drugs, is known every week, it seems. So with her presentation, then afterwards, we will have a live Q&A and mention to you another CME event that's planned for May. So that's just a teaser for now. But without further delay, Karen, take it away.
Thanks, Tom. Appreciate everyone being here, listening in. Okay. So my goals for today really are to discuss the chronic and progressive nature of the disease of obesity, review a little bit about the AAP 2023 obesity treatment guidelines, and discuss how obesity is diagnosed in the clinical setting, discuss a little bit about the rationale of using anti-obesity medications in pediatric obesity, as well as discuss the use of bariatric surgery to treat severe obesity, and identify which patients or families to refer to either our bariatric surgery program or our medical weight management program, the Wellness and Weight Management Clinic. So I always start out by reminding everyone that obesity is a complex, multifactorial, relapsing, progressive chronic disease that results from inappropriate regulation of energy and body fat mass. And in fact, it's the number one chronic disease of childhood, except for maybe dental caries, and affects approximately 1 in 5 children and adolescents in the United States. And historically, the obesity phenotypes always existed, but really our environment has changed dramatically over the last 3 to 4 generations. Twin studies that were done in the 1980s, as well as the genome-wide association studies, tell us that approximately 40% of a person's risk for obesity comes from a mix of genes from the two sides of their family. So it's polygenic in most cases. But there is a robust genetic gene-environment interaction that ultimately determines the individual's risk to struggle with obesity. And then we've all, at this point, should have heard about the AP guidelines for the evaluation and treatment of children and adolescents with obesity that came out in the beginning of 2023. And really, these were the first comprehensive guidelines. There previously had been some consensus or expert opinion, but these were very comprehensive guidelines that came out. And really, a key sort of difference from previous recommendations was that pediatricians and other pediatric healthcare providers should really start intensive health behavioral lifestyle treatment and offer other treatment options as soon as obesity is identified in their patients, as opposed to watchful waiting, which was often for a period of time, which was often the previous recommendation. Obviously, this treatment needs to be done in a very non-stigmatizing, collaborative way. And actually, I think that the medical home is the perfect place for this to happen, where you have long-term relationship with your patients and families. So really, these guidelines talked about early intensive treatment in the medical home once diagnosed, regular monitoring for obesity-related comorbidities, identifying and addressing social drivers of health. Like I said before, using non-stigmatizing approaches to collaborate with your patients and families, prescribing anti-obesity medications when appropriate, and referring to medical as well as bariatric surgery programs to qualifying patients. So how do we diagnose obesity in pediatrics? It's by looking at the BMI. So in pediatrics, it's actually the BMI percentile for age and sex, and we use it as a surrogate for body adiposity or fat mass. And again, BMI is definitely not perfect, but what I would say is that it is pretty specific for identifying excess adiposity in patients with severe obesity. It can be a little bit more inaccurate or problematic when we're talking about patients in the overweight or class 1 obesity category, and it can both over and under identify patients with obesity depending on various factors and patient characteristics. But again, at the extremes, it tends to be really good. And we need to, again, take BMI when we're diagnosing a patient into consideration alongside other individual patient characteristics, such as lifestyle behaviors, family history of disease risk, as well as other cardiometabolic biomarkers like blood test results. And then, like I mentioned before, we use BMI as our screening and our screening tool. And then we classify obesity into class 1, 2, and 3. And severe obesity, when we talk about it, is really patients who are at the 120th percentile of the 95th percentile. And it's class 2 and 3 that are considered severe obesity. And that's what we're talking about in terms of treatments today. So this is a classic graph of our treatment armamentarium, and really personalized multi-component intensive lifestyle behavioral interventions is the basis for everything that we do. Today, I'm mostly going to talk a little bit about pharmacotherapy and bariatric surgery. Unfortunately, more of these advanced therapies listed there are either an excluded benefit or not covered by many insurance plans for pediatric patients. And in fact, endoscopic procedures and devices, really, there are none that are FDA approved currently for patients under the age of 18. And they're mostly used in the adult space. And I would say those treatments, we need to consider them all often, either separately or together over the lifespan of our patients with obesity, because again, it's a chronic disease. So this is a slide just showing it's a Nature Review article that just shows the average weight loss percent by treatment modality. And as you can see, while lifestyle changes alone can work for some patients or some individuals, it's often not enough to change, especially those comorbidities or complications that can come along with obesity. And then the anti-obesity or obesity management medications, often you can expect anywhere from 3 to 15% average weight loss. And then bariatric surgery is anywhere from often 20 to 30%. So who should you consider prescribing obesity management medications to? So according to the AAP treatment guidelines, any patient who's 12 years or older with obesity. So I would say especially patients with class 2 or class 3, what we consider severe obesity. The prescribing of medication should always be accompanied by personalized behavioral lifestyle treatment. And the prescribing provider should have knowledge and training on the use of these medications. And these patients, when you prescribe medications, really need close and ongoing follow-up. And I'm not going to get into the details of each of these medications, but this is a schematic of the most common medications we use in the wellness and weight management clinic. And they go in increasing order of average effectiveness from left to right. And some of these medications are medications that primary care physicians prescribe for other health issues. And therefore, I would argue that they shouldn't really feel nervous using them off-label for obesity management. And those include things like metformin, topiramate, and lisdexamfetamine. And then, so like we said previously at the onset, the GLP-1s, since being approved, and they are FDA approved, specifically liraglutide and semaglutide are FDA approved for patients 12 years and older. Some of the issues, though, unfortunately, are that these newer medications that are much more effective than previous off-label medications that we've been using for a while are, like I said previously, excluded from many patients' insurance plans. And the cost of these medications, while they have come down, especially in the last 6 months, are really much too expensive for often the majority of the patients and families that we see. And unfortunately, the issues with access are contributing to health inequities. I'm going to move on to bariatric surgery. But why should we consider bariatric surgery in a pediatric or an adolescent patient. Like I said before, obesity is a chronic disease which leads to serious comorbidities and decreased quality of life. And often surgery during adolescence can have a much more profound effect on both the prevention and or amelioration of associated chronic diseases and complications, as well as the psychosocial trajectory of the patient. Outcomes from surgery in terms of the amount of weight loss and resolution of comorbidities is better, often in patients at a lower BMI and less years of disease. And really, like I said before, currently bariatric surgery is the most effective as well as durable treatment for severe obesity. And Dr. Injit colleagues now have information out 10 plus years on patients that have adolescent patients that have undergone bariatric surgery. And then this is just a schematic or picture of the two most common bariatric procedures. But really around 2014, the sleeve gastrectomy overtook gastric bypass as the #1 performed procedure, and for various reasons, but it's very close in terms of effectiveness. It's a shorter procedure, less complications. And so for all of those reasons, it's often the procedure of choice for the patients that we see at Lurie Children's Hospital. And so which patients should you consider sending to our bariatric surgery program? Like I said before, patients generally with severe obesity, so class 2 or 3. And this is the AAP section on obesity's 2019 policy statement on bariatric surgery, which really states that a patient with class 2 or a BMI at the 120th percentile of the 95th percentile, you should refer them if they have a significant comorbidity related to their obesity, and those are listed in the box, or a patient with class 3 obesity or a BMI of 40 or the 140th percent of the 95th percentile with or without a comorbidity. And really, this is just a slide showing the teen labs, which is Dr. Ind was the PI, the lead author on many of these publications that have come out of this cohort of adolescents. And this is the 3-year outcomes, which again compared sleeve to bypass in terms of percent change in weight from baseline. But also, if you can see over on the right-hand side of the slide, it shows that there is significant improvement in these comorbidities that often come along with obesity. And so, in conclusion, obesity is a disease that affects a large percentage of children and adolescents, and watchful waiting is not generally helpful. Pediatric patients are developing complications of obesity, which impair quality and duration of life. And often the diseases or those complications that come along during childhood can be more aggressive than those same diseases that an adult may have. And there's an increasing number of treatment options, luckily, to help our patients that are struggling with obesity, and we all need to become familiar with them. And then studies on metabolic and bariatric surgery show us that timing is everything, that there's this adolescent privilege, which is a window of time for optimal reversal of things like type 2 diabetes and high blood pressure. And in general, the use of anti-obesity medications or obesity management medications in metabolic and bariatric surgery do carry risks and should be used with knowledge, responsibility, and appropriate follow-up. But long-term advantages likely outweigh the disadvantages. And access to care does continue to be challenging across the country, but luckily you do have options here at Lurie Children's Hospital. Thank you.
Thank you,
And I'm
Dr.
happy.
Morelli. That was great. You covered all the bases. I'm going to go ahead and share my screen.
Okay.
There's a road management roadmap here. Did you want to go over that? I'm sorry.
Yeah, we can. I didn't know if this would be a question that's out there from people, but I would say a quick just overview of this is just in general, I would say that patients with obesity, or I should say patients who have overweight or class 1 obesity without comorbidities may be appropriate for primary care pediatricians to follow and manage within their medical home. But it's the patients with either class 1 with a comorbidity who you should consider sending to wellness and weight management, or obviously patients with class 2 or class 3, so severe obesity. And really, I think it's imperative to have these discussions with the patients and families. I often say that it's our job to let them know about what their treatment options are, and then to think about those options, decide. And again, your patients with class 2 or class 3 obesity, if they're interested in bariatric surgery, you do not need to have them come through the wellness and weight management program. They can be directly referred to our bariatric surgery program.
Excellent.
That's it.
Thank you.
Thanks, Karen. Yeah, the very thoughtful, practical presentation, and I really appreciate everyone joining us today. As you heard from Karen, there's a big spectrum of things that we can do. I believe that bariatric surgery is a really spectacular treatment modality for weight in general, but certainly for the complications of severe obesity that are stealing lives and happiness and years of happiness from our patients down the road. Diabetes is one of those complications of obesity that we have the ability to reverse, and reverse, of course, their risk of complications of their diabetes by reversing the diabetes itself. So I really do think that no matter which therapy is most appropriate for the patient, we've got to offer these therapies, both the surgical and the intensive medical therapies, and that will be a topic for our upcoming symposium on May 5th. We call it the Scopes Symposium. Chad, can you pop up the slide for that as well? So that's surgical care of obesity and pediatrics. It'll be here at 211 East Chicago, right beside us, right beside Larry's main tower. And we'll have virtual options as well as live options and CME through Northwestern. Very interdisciplinary, broad lens for that. So with that, be happy to, with Karen, take any questions.
That's great. We got some questions in. First one is, does weight and wellness manage comorbidities with, say, endocrinology for prediabetes and cardiology for cholesterol? Or should PCP be making individual appointments with different disciplines?
Great question.
Yeah, so that's a great question. And actually, we're going to be working on this in the next 6 months specifically. But I would say that, yes, we do manage the vast majority of the comorbidities within wellness and weight management. The patients do not need to often be referred. That said, each of the subspecialty divisions there's certain patients when they reach a certain threshold that they do want to see. So for example, if a patient's hemoglobin A1C hits 6.5 or higher, where they actually do have type 2 diabetes, they absolutely should be referred to endocrinology. Or again, for preventative cardiology, if they have dyslipidemia and they have an LDL cholesterol often at 130 or higher, or they have triglycerides at 300 or higher, often they are going to want to see the patients. But those patients that have sort of levels that are lower than that are often we follow and manage within the wellness and weight management program. So yeah, more work on this to come in the near future.
But it shows our great collaboration we have with our multidisciplinary teams here at Lurie Children's, that we're able to provide so much care for so many of our patients. So it's
Jay.
And our program, we are located in 2 different areas, right? So we're at the main hospital at Lurie Children's downtown. And then we offer services at the Winfield campus, correct? That's over at Central DuPage Hospital.
Yeah, absolutely. That program actually, from a surgical standpoint, preceded the downtown location program and has carried on ever since. We see patients there for medically complex obesity, for pharmacologic therapy through our nurse practitioner, Alyssa Williams, seen here in the photo, actually, a second from the right. And then our partner on the surgical side there is Guillermo Aris, who's our primary surgeon there. I go out to CDH to operate with him once a month. And so it's a team effort there from the standpoint of surgical safety for these high-risk patients as well.
Thank you. So our partners here in the Chicago community and Chicago area are familiar with us, and they're great partners. But let's talk about being able to refer into our program for those patients who reside outside of the Chicago area. We're happy to take those referrals as well.
Yeah, absolutely. You see the numbers on the screen as well as our email. So in addition to the local internal referrals that are in baskets or orders in Epic, the external referrals from our system, outside our system, that is, can get to us in multiple ways, as you see here on the screen, phone as well as email.
That's great, because there are so many outside of the Chicago area that need our services as well. We encourage you, for those who are watching this video, to contact Lurie Bariatric Surgery at luriechildrens.com so we can assess the value, how much your patient needs to be seen by our team. Go
and
ahead,
I'll
please.
also add, Chad, if I might, that email address could also be used for just point of care questions or the day after care when you have a minute to jot something down. If there's any way our expertise could help with patients and decision making in the office, or if you'd like just what's the latest and greatest in the literature, having us send you a preprint or a reprint rather of some of the work we've been involved with in the peer-reviewed literature, we'd be happy to share that.
Well, thank you. And you touched on my next question, because there are probably a lot of patients seen by their PCPs that may be a borderline case. When is the most opportune time for them to reach out to you and say, hey, I think I have a patient that we want you to see?
Yeah, so you might get a different answer from Karen or a different perspective, but I think that in the algorithm that she laid out, it's very clear there. And some people might see these as conservative guidelines. Some people might see these as aggressive. I see them as realistic and evidence-based. In other words, if a patient has reached a BMI of 35 or 120% of the 95th percentile, and major comorbidities of obesity, we'd like to know about it. Insurance will definitely look at things carefully and will definitely be a topic to make sure that we have the ability to document the comorbidities at a BMI of 35 or 120%. At a BMI of 140% of the 95th or 40 as an absolute and above, we don't require a comorbidity per se. That's not to say that they won't be there. There will be comorbidities usually. But I think that our average here, BMI at the time of referral, is in the 50s. And I will hasten to say that's not ideal. That is delayed care, I would say, and not pointing any fingers at the reason why things get delayed like that. But if we can get to patients and get services to patients earlier in their climb in this severe obesity spectrum, now actually officially there's 5 classes of obesity. But if we can get to them earlier in the spectrum when they meet surgical criteria from a surgeon standpoint, rather than late, we can expect a better outcome. And so I think that it's really quite important, the question that you asked. And so I'm glad you asked it. Karen, you may have, again, a medical perspective as well.
Yeah, again, I think that these are really difficult topics to have with patients and families. But again, I think that starting these conversations in the medical home is important. And again, the cutoff for where healthy, unhealthy is different from person to person. When we delay treatment, when we wait, like when it's considered something like the last resort, it's also not helping our patients in any way as well, because of the fact that the longer you have disease, the worse off that organ or organ system is going to perform, and the less likely it is to reverse those disease processes or to put it into remission. And again, this comes down to quality of life, and people really inappropriately assume that children don't have really severe comorbidities and complications related to their weight. But we see kids with significant issues that people think are just adult problems, and they're not. And so again, our job is not to like scare patients and families, but it is to work with them over time to decide what and when they think is the right time, or what sort of treatment options they're ready to consider over time.
I think that's important. Thank you for doing that. I have two questions. One is going to relate to the mental health aspect that we're going to touch on tomorrow, and when I get to the next slide to promote tomorrow's slide. But I want to touch on the BMI real quick. And right now, there's a lot of talk about visceral fat and the visceral fat around organs. And the things I read, it seems like it's more of an adult problem, but it's also an adolescent and child problem as well. And this procedure helps with the visceral fat too. Am I correct on that?
Yeah, that's 100% correct. In fact, our observations tell us that it's the visceral fat that is the earliest to be resolving or going away after surgery. And in particular, when we say visceral fat, that includes a lot of organ compartments, but the liver in particular, we can see really the vanishing of steatosis very quickly after surgery. We can also see, fortunately, the vanishing of inflammation in the liver that's due to the fatty liver disease, as well as scarring. I think that you raise a really good point that this is not just about quote unquote weight loss, it's about fat loss. And that's really the important part of this, because all of the excess visceral fat tends to drive the four horsemen, the real causes of early demise.
Yeah.
Dr. Magro, you brought up, Dr. Magro, in the earlier part of your presentation, genetics.
Yeah.
And is genetics a big part of the visceral fat? Because some people will have a lot of visceral fat, but they'll look healthy. And some people won't look healthy, but they don't have a lot of visceral fat. Is there a correlation there with genetics?
Yes, absolutely. Again, when it does matter where you carry your excess adiposity in terms of disease risk. So there is a genetic component. It does matter where that excess adiposity is located in terms of disease risk. And when I mention, yes, BMI can both over and underestimate obesity depending on the patient. Again, that gets to how certain populations may have their excess adiposity in areas different than other populations. And yes, there is definitely a genetic component.
Thank you. And that's where yesterday's session about nutrition really comes in hand too, where the more we can educate on nutrition, the better we can with that too. I'd like to end our session here and talk just quickly about tomorrow's session, because that is it's so important, the mental health considerations for our children dealing with obesity. Can both of you touch on that a little bit and talk about how important tomorrow's session is?
Yeah, I mean, I would say that this is so important. Patients living in larger body sizes are stigmatized. They, like, over the course of their lifetime, this very much affects kids. It's the number one reason for bullying. Again, these things come together. And certainly our job, like meaning in healthcare, is we should ideally, like I said before, we should be coming alongside our patients and families. We shouldn't be scaring them. But at the same time, we should be giving them some hope that there are treatment options for them. And I would say the other piece that doesn't get talked about enough is that patients with obesity do have not only higher risk for things like depression, anxiety, but they also have higher risk for eating disorders and disordered eating patterns. And again, I think that you have to be very thoughtful about what's happening with your patient and family. You should not make assumptions, asking, like, again, open-ended questions, because again, ultimately, we don't want to do any additional harm, right? Yes, extremely important.
And I just wanted to add from a research space, absolutely very important. Kelly Lowry is really a terrific team member. I wanted to add, though, that from a quality of life standpoint, we've looked at this carefully in research populations of teenagers undergoing surgery in various domains: physical functioning, psychological well-being, social functioning, and then health-related quality of life. We've noticed just dramatic improvements in these domains, but it's a complex equation. And over time, these improvements that are seen early after surgery, these same individuals are back into their usual environment, their usual routines, and it's not a panacea. And so the complexity up front is there. A bump or boost from surgery and weight loss and getting to what they would consider a better BMI and body habitus is there, and comfort. But then again, life goes on, and we need to be there, I think, along with pediatricians and the primary care providers with them as they transition to adulthood, to make sure that they have that continuing support.
Thank you. Thank you both very much. For those of you who are online still or watching this video, I highly encourage you to join us tomorrow for session 3, mental health and behavioral health considerations for youth with severe obesity. We'll have an introduction by Alyssa Williams, and then Dr. Kelly Lowry will be presenting. If you are watching this recording, I would highly recommend for you to watch the next video of session 3, as this will be a very big component with treating your patient. So with that, I'd like to thank everybody for joining us today, and like to remind those of you who are watching that it's easy to refer into Lurie Children's. You could scan in right here, this QR code. Will take you to Lurie Children's Physician Services webpage, where we have a lot of immediate access for you about our provider schedules and where they are practicing, our referral guide, quick reference phone numbers, locations of all of our services here at Lurie Children's, and patient referral forms and laboratory requisitions. Dr. Idge, Dr. Mangarelli, thank you so much for joining us today and for all this important information.
Thanks.
Chad,
Thanks for having us.
Okay, thank you. Have a great day, and be sure to like this program.
Bye-bye.